Hi, this is Maria RIBAL from Urology Unit, Hospital Clinic, University of Barcelona. And I'm really happy to be here with all of you in this urology symposium of the Chinese University of Hong Kong. I would like to thank the invitation to be with all of you, especially to my friend, Professor Jeremy Teo, that we are working all together in the guidelines. So really thank you for being here with all of you. Today we will address how to manage elderly patients with muscle invasive bladder cancer, and this is not uh, an easy issue. These are my disclosures, and we will go directly to the issue of this talk. And look, the first that we should be aware of is that we are facing an aging population. The size of the elderly population worldwide is increasing, and it has been calculated that by 2030, the number of people over 80s will increase till 200 million. And for 2050, it will be more than 400 million. So this demographic shift poses profound questions as to the ability of medicine to meet the health needs of the oldest strata of our society. So looking at our guidelines, this is a version and the update of 21, but this statement is there for a long time now. It's that chronological age is of limited relevance. So the truth is that we cannot consider someone at 70s, for example, on the trials, or over 65 as our elderly people. We need to be sure which is the life expectancy of these people and base our recommendations on this analysis and on this evaluation, because age is not enough to deny radical therapy in these patients that they have a very important and an aggressive disease linked to mortality. So the truth is that despite all of this, older bladder cancer patients are less likely to receive a standard therapy. But on the other hand, we should be aware that not treating a very aggressive disease could impair quality of life and cancer-specific survival, even in those old patients. So taking into account an individual's life expectancy and goals and preferences and clinical decision making must balance the benefits and risks of treating against the morbidity and mortality arising from untreated or undertreated cancer. And in this context, we did a multidisciplinary task force of the Society of Geriatric Oncology. And we did a consensus, and we tried to review all the areas to make recommendations on how to treat patients with bladder cancer at this age, at this old or elderly phase of their lives. The first is that we need to be sure that evaluation is necessary. We cannot face how to treat elderly patients with a proper evaluation. And since age per se is a poor guide to the for the physiological and functional status, the concept of geriatric assessment is gaining momentum, and especially in the oncological frame. The truth is that we have some tools that could help us to identify how is this patient, which is his or her frailty, and then to decide how to treat based on this information that evaluates patients' physical function, cognition, nutrition, comorbidities, psychological status, and sources of social support. So, geriatric assessment that could be done based on G8 and mini-COG needs to be followed by interventions implemented in response to any vulnerabilities identified. And these interventions should be done by a multidisciplinary team that should include physicians, nurses, psychologists, social workers, nutritionists, occupational therapists, physical therapists, and even pharmacists. So based on this classification, then we can decide if we need a geriatric intervention or if a geriatric intervention is not needed, based on the classification of the patients in a healthy group or a frail with reversible problems, a patient with a very severe comorbidities that are not able to be reversible anymore, or if we have a terminal patient in front of us. So look, how important is it that in the 21 version of our EAU guidelines, you will see that we have created a new section based on the evaluation of the health status. And this section has been updated and it has been included the concept of frailty. So this is important because we realized in our guidelines that age could not be considered anymore as a cutoff to decide how to treat our patients. And we decided that we should include guidance on how to evaluate these patients. So it's for that we decide to include in our guidelines, which are the main tools we have for evaluating these patients. And as you have already seen before, we incorporated not only the G8 screening tool that, as you can see, is based on different evaluations of different status, giving a score, and also we incorporate the clinical frailty scale that could be of help to evaluate our patients. So we are not the only society working on that. ASCO, for example, in 2018, they already made an assessment on how to evaluate patients for being submitted to chemotherapy, for example. And they recommend that life expectancy should be estimated, that a functional assessment is necessary, that also to evaluate comorbidity in these patients is really important, that perhaps we need to incorporate when a patient is going to be submitted to chemotherapy, a comprehensive geriatric assessment. And as you can see, this is not only important for localized disease, but also for metastatic disease. So basically, we cannot talk about treating older bladder cancer patients if we don't incorporate in our routine practice a geriatric assessment. So this is the main message. The main message is that we need to incorporate in our clinical practice, in our NDT, a geriatrician able to evaluate these patients. Because no treatment should be denied based on age alone. And it's important to incorporate this in the global assessment. Look, I will explain you now a personal experience. This is a work we did in our area, in the Barcelona area, based on patients treated in university hospitals. So it was a multidisciplinary team from Barcelona hospitals. It was a retrospective multi-center study with a little bit more of 300 patients that all of them were older than 85. Look, that we are here not using the age that commonly used on trials, but real older patients more than 85. And the data was recruited between 14 and 16 from 6 tertiary hospitals. And we want to analyze how they are treated for bladder cancer. We decide that we will use as a standard therapy those that the guidelines, EAU guidelines, give us as a standard therapy. And a standard management was considered at that moment as surveillance in low-grade non-muscle invasive bladder cancer, BCG instillations or restaged URV in high-grade non-muscle invasive bladder cancer, and cystectomy, radiotherapy, or chemotherapy in muscle invasive bladder cancer. Palliative management was considered as monitoring patients and treating them according to their symptoms, but without applying oncological or invasive treatments during follow-up. They could be managed by analgesics, bladder irrigation, transfusion, radiotherapy or chemotherapy in a palliative way. And in contrast to the standard management group, patients admitted to palliative care were not treated with a schedule TURB in case of non-muscle invasive disease. We evaluate both, not only muscle invasive, but also non-muscle invasive. And look, this is the results in our community, and you can see that only 32% of muscle invasive bladder cancer patients were managed with those that we have considered already the standard therapies. So obviously that our work have some limitations because it's a retrospective study based only in one area, but we can see that the use of standard therapies in this aging population is less than in younger one, and that we need to assess which is the functional status of these patients to be sure that we don't deny the therapy based only on age. So this is our area, but what happens in the worldwide? How in the world they are treating these older patients? And you can see that it's more or less the same in this cohort of older adult patients. Older patients were less likely than their younger counterparts to undergo radical therapy for invasive disease. Only 12% among patients aged at 80s and older, compared to 52, that it's not a big number, were treated accordingly to the standards, and obviously there was a higher cancer-specific mortality. So globally, there is an extensive undertreatment of all the adult patients, and in most of cases they are not affected by metastatic disease with no chance of cure. They have chance of cure. So we need to change our mind. We need to be sure that we are able to incorporate the proper evaluation of these patients and that we are able to give them the proper therapy. So this is another systematic review. And it's true that perhaps all the patients are not submitted to the standard therapy because they exhibit more complications or morbidity derivated of this therapy. And the truth is that in this systematic review, they see that it's true that perhaps in older population we have an increase in perioperative mortality, but morbidity seems comparable to the younger patients. So again, the same message, elderly population probably will benefit from a standard therapy, but it's important to submit them to a proper evaluation. So what we can say about treating elderly patients with muscle invasive disease, that we need to evaluate them as we do with our youngers, and if we should establish a pre-habilitation model, it should be done, that we can use the same thromboprophylaxis that we use in those that are younger, that perhaps in surgery, well, you can think that perhaps avoiding bowel surgery for reconstruction could minimize the complications coming from this technique, but with a payment of an increase in bilateral ureterostomy. And the role of lymphadenectomy in these patients, it's not clear, but probably if we are going to submit them to radical therapy, probably we should do in a full conditions, making a proper lymphadenectomy, and obviously we need research on this area. So in this consensus that we already published 1 year ago, we see that there's an increasing and extensive undertreatment of older patients, that independent of age and fitness, patients with muscle invasive bladder cancer should have a proper staging, just for identifying the extent of the disease, that the choice of a standard treatment for fit patients differs between countries and practitioners, but radical cystectomy and trimodality therapy could be a first-line options. If radical cystectomy is decided on, they should be referred as most of radical cystectomies, to an experience center. And in the metastatic setting, we should do more or less the same. We should evaluate our patients. We should discuss with them the chemotherapy for metastatic setting. They should be considered for standard therapy, but if not, carboplatin is an alternative. And even now, immunotherapy in those patients with PD-L1 staining. It's true that the efficacy and tolerability of immunotherapy in older patients could be not the same that in younger, but still we don't have proper recommendations on that. And palliative radiotherapy could be considered for treating conditions as intractable gross hematuria or even for control of pain. For sure, we need more research in this area. There is a lack of clinical trial assessing how a proper therapy works in this elderly population. Why? Because they are not admitted in most of the trials. This is a criticism currently for trials, that they should incorporate these patients in their designs. So, which could be recommendations for the elderly population? First, as general aspects on treatment, localized disease, we should recognize that there's an extensive undertreatment, that independently of fitness, they need to be proper staged, that standard therapy like cystectomy and trimodality therapy should be offered, that they should be referred to experience centers. If they are fit enough, we should consider neoadjuvant and adjuvant therapies. And regarding localized disease and precisely surgery, we should apply an ERAS protocol. We should treat perioperative anemia. We should make them fit for surgery, use a common protocol of thromboprophylaxis. Perhaps we can decide about avoiding bowel reconstruction. There's no data conclusive on avoiding lymph node dissection. And radical therapies as trimodality therapy and cystectomy should be done on referral centers. Regarding metastatic bladder cancer, proper palliation should begin at the time of the diagnosis. Standard therapy is cisplatin-based chemo. Carbo could be considered, and immunotherapy also. It's true that immunotherapy are tolerated similarly in younger than in olders, but we need definitive data on that. Second-line immunotherapy are standards in those progressing on cisplatin, and we can use palliative radiotherapy for gross hematuria or control of pain. So many of the patients who are assessed in routine clinical practice in oncology are older. Comprehensive geriatric assessment is the basic tool by means of which to evaluate older people with cancer and to understand their needs. It's no longer reasonable to ignore the fact that this is a very special group that requires specific interventions. Aging is a highly disparate process, and as such, and given that chronological age does not always correspond with biological age, a patient's date of birth should not be used as the sole discriminatory element when embarking on a diagnosis process or establishing the best treatment option for a neoplastic disease. Thank you very much for your attention.